Okay, we're moving on now to Jonathan Karnon, who is from Adelaide University. Take it away. Thank you.
Thanks, Alan. So I'm presenting the first of 8 research ideas that we selected from 28 or 29 that were submitted, and so it seems like there's a bit of bias maybe, but hopefully I was removed from the selection process. So the research idea I'm going to talk about is some work that we've been kind of working on for probably, since I arrived in Adelaide really, which was in 2007. So it's involved a broader range of researchers than are named here, but these are my collaborators who've kind of been working in terms of translating or transferring those methods specifically to transforming health, so thinking about how we can use the methods to support transforming health. And so just got 5 slides, that's what we were allowed. So I'm going to kind of give a broad overview of the general concept, evaluation algorithm, then talk about the rationale for evaluation in the context of transforming health specifically, talk through study design in a bit more detail, give an example of applying these methods previously, and then give an example of how it might be applied to a particular example in transforming health. So, evaluation algorithm with respect to transforming health. So we've heard from Dorothy that there's 50 different working groups are going to be set up in the first instance, to identify ways in which services can be improved, so specific services for specific patient groups. And so we're going to have all this change going on over the next 4 or 5 years. And we want to make sure that it's having some effect, but also bearing in mind this objective of continuous improvement. So the first question is here: we make a service change, do we see an improvement in quality and efficiency? And by efficiency, I'm talking about quality improved at reasonable cost. Or what is the cost impact of any changes that we see that maybe vary from what were intended. And so one of the questions here is, one of the key questions to consider is, how do we measure quality? It's always, whatever we're doing is always a big issue. With respect to service change, it's commonly been looked at with respect to outcomes or processes. And so if we're taking either of those, how do we measure outcomes, how do we measure processes? And then moving on from just this kind of aggregate evaluation of does quality and efficiency improve, digging down a bit to inform that further continuous process. Firstly, we can think about whether there's the scope for further improvement. So we make some improvements, what's the scope for improving quality and efficiency further? And linked to that is, are we getting consistent improvements in quality, or are we getting variations? I mean, we're kind of assuming one of the bases for transforming health is variation in the way that healthcare is provided. So are we reducing that variation? And that variation may be with respect to the time at which patients present or patients are treated, or it may also be with respect to the location. So are different hospitals providing different levels of quality and efficiency? And so that will inform how we move forward in terms of continuous improvement. And so the question there is, how do we benchmark? So how do we decide that we've got to an adequate level of quality, or how do we decide that we really need to focus on particular areas to improve services further? And then that leads into the question of what level of quality and what level of consistency is achievable or feasible, because achieving quality, achieving consistency isn't costless. Whilst one of the objectives is to improve efficiency, there'll be a point at which we kind of maybe have to say, all right, we've got this level of quality, we could go one step further, or we've got this level of consistency, we could try and improve consistency even further, but at what cost? So it's a question of opportunity cost. Are the benefits that we perceive or we're aiming for from improving quality further or reducing variation, might we get better or more benefits from spending the cost that would be required to achieve that elsewhere. So these are kind of broad, general evaluation questions that I believe we should be seeking to answer, and that the methods that I'm going to describe will hopefully move towards. So I want to absolve my co-authors from this next slide. This was a result of a brainstorming session of one. And it's really just kind of providing the rationale for evaluation, because as researchers, we evaluate. And so whatever the health service is doing is, you've got to evaluate it. And so I thought, well, the way that Transforming Health has been put together, and as Dorothy was describing, I think is unprecedented, certainly in South Australia, in terms of the level of involvement of the clinicians, the engagement with the community, the setting up of individual working groups to focus on specific areas of service improvement. I mean, you really can't fault the process, but that doesn't necessarily get around this so-called law of unintended consequences. There are still things that could happen despite all the best plans. And so I've just kind of, as I say, a brainstorming session of one, just thinking through some of the working groups that are on the table at the moment, and if nothing else, this might provide some source for questions to tell me that I'm talking rubbish. So starting with stroke, the plan is for a single service, multiple site stroke service, and the kind of from my reading, the cornerstone of this is that there's going to be 3 locations where stroke services are provided: Flinders, Lambert-Ewan, and the RA. But out of service or out of hours services will only be provided at the RA. So if you have a stroke out of hours, you're going to be taken to the RA. And clearly there's a strong rationale for that, and there's evidence from the UK where they've also moved towards a centralised stroke service that's shown benefits. So it's based on evidence-based health service improvement, but there are still potential risks. So all out-of-hours patients are going to be taken to the RA. There's a spectrum of stroke patients, maybe varying risk benefits across that spectrum. So not all patients might benefit from that change. Also, potentially, given that the RA is going to be the central focus of the whole system, there may be an unintended focus on the RA, and the other hospitals become a kind of second-tier service. And so evaluation of the implementation of those changes is important to, if nothing else, just to check that those things don't happen, and if they do, to identify where and what could be done to address those issues. A second example is the changes to the rehabilitation services. Again, major changes. We're moving from a standalone service where patients are essentially transferred between hospitals at the point at which they need a rehabilitation, to an integrated process where as soon as the patient is ready for rehabilitation, they receive that rehabilitation in the acute setting. So again, evidence-based, highly developed plan, but again, there are potentially unintended consequences that we need to evaluate. So the aim is to have shorter aggregate length of stay, because patients are getting the rehab quicker, but potentially they'll be spending more time in an acute setting with the risks of infections, falls, etc., that may be higher in an acute setting than in a subacute setting. I also highlight the potential for what I've called rehab creep, the fact that more all rehab services are within the acute setting means that maybe more patients will be receiving rehab that would previously have received it, and the benefits of that rehab may not justify the cost, but it also may reduce capacity for patients who actually need the rehab. And finally, another potential consequence is conflict and management plans, where you've got clinicians looking after the acute needs of patients and looking after the rehab needs of patients. If there's conflict, again, there may be things to look at. So again, just kind of thinking through some potential things that evaluation can help with, and as I say, completely open to criticism on these ideas. The final, more general issue is around this move towards 7-day healthcare, which is kind of an overarching objective of transforming health. And here we can draw on some work again in the UK, which is another area where there really been a lot of interest. And some health economists did some analyses there that showed that, or estimated, that it was going to cost around £1.25 billion to provide 7-day healthcare. And in terms of mortality, the best that they would hope to achieve would be to reduce mortality by around 5,000 excess deaths a year, which gives what we call in the health economics trade an incremental cost effectiveness ratio of around $500,000 if we transfer it to Australian dollars per excess death avoided. And so there's the issue of whether, again, opportunity costs is the money spent to avoid excess deaths best spent there, or could we get more bang for our buck from spending it elsewhere? So again, it's just something that can be monitored, evaluated as Transforming Health is rolled out to inform the progression of the initiative. So study design. So this slide is around some of the strengths and limitations that are relating to the type of study, the type of data that we can collect and analyse to evaluate transforming health. So if we take as our aim is the continuous assessment of both the quality and efficiency of healthcare in South Australia by time and location of treatment, we can think through the strengths and limitations of the options with respect to collecting and analysing data. So the first issue when we're thinking about study design is whether we can conduct a randomised controlled trial. Clearly, in the context of transforming health, unless Dorothy's going to contradict me, that's probably not possible. And so we're stuck with observational studies, and so we need to think about potential confounding, the fact that patients treated at different times, different locations have different characteristics, different risks, and so we need to control for those potential differences. Secondly, what kind of data can we collect, or what can we use? Again, the ideal would be what we call de novo data, where we say, right, this is the patient population we're evaluating, these are the outcomes we're interested in, this is the data that we should be collecting to inform that evaluation. Again, not possible in terms of defining a general framework for evaluation, and so we have to use routine data or routinely collected health service data, and that raises issues around unobserved confounding and whether we can actually measure what we want to measure in terms of relevant outcomes. So those are the limitations, but the remaining characteristics of the study design I think are real strengths. So firstly, again, when we're designing a study, we're thinking, well, do we need to take a sample of the population that we're interested in? And in this case, clearly we don't. We're actually collecting data because we're using routinely collected observed data. We can collect data on the whole population of patients within each of the service areas that we're evaluating. This eliminates selection bias. It also means we've got the largest possible numbers, which helps with the power to be able to detect effects and differences. In terms of the outcomes or that we can inform, SANT Data Link is a major resource in South Australia, and through data linkage we can now link data between hospital episodes, and so we can look at outcomes beyond discharge. And so I think a major weakness of a lot of health services research is that it only looks at outcomes within an acute or single episode, and so we can go beyond that and look at more meaningful outcomes. And finally, we can look at more than patient outcomes. So as I mentioned before, often it's a choice between process or outcome indicators. Here we can actually look at costs, outcomes and processes, and that provides a basis for triangulating our findings. So if we see a difference in outcomes, does that correspond or tally with any differences we might see in process as well as costs? and it also better informs the scope for further improvement. So just a very quick example, which some of you may have seen before. This is some work we looked at chest pain presentations across South Australia. So again, it's a population-based study of all presentations to an emergency department with chest pain, and we've got our 4 main South Australian hospitals here, unobservable. So we can see that Hospital 2, the red circle, has got worse outcomes, higher costs, and looking quite significant with respect to outcomes. And we also looked at processes to see what might be driving those differences, and we can see there's Hospital 2 was admitting far fewer patients and was tending towards less use of invasive management with those patients. So that's just a very quick example, because I'm getting the time. And so my final slide is just to give and I'll leave this one up, is just to kind of give an example of how these kind of methods could be applied to one of the working groups that's currently in operation, which is the rehabilitation services. So it's talking about the eligible population, which is clearly anyone who's undergoing a procedure for which rehab is common. What are we comparing? Well, we're comparing rehab provided at different hospitals for different procedures, maybe different times of the day, of commencement, different days of the week. We've got a whole range of process indicators that we can draw on routine data to support our evaluation and also for outcomes. And then just to finish, the final thought is that this process is obviously very quantitative, and it's really just providing, in a way, a kind of screening tool to identify those areas in which further, more detailed analysis, perhaps qualitative analysis, could be undertaken to confirm and develop a further improvement plan. So I'll stop there.
Thank you, John. Unfortunately, we don't have a time for questions.
Oh, no.
Stay tuned. We're going to have a break at 3:10, but I just need to keep the ball rolling.
Yep, sure.
Tough. Thanks, John.